here, this is almost around 53%. See, look at the machine itself, gives you the plaque burden here. This spot, it is around 53% plaque burden. And there is not much of lipid and calcium, as I already told you. So if that is the case, I think we won't get a better place to land our stent than this in this patient, because it's almost a diffuse disease patient. And now what I have done is, uh, see, I have placed a stent, 38 millimeter stent here. And if in our lab we have angio registration, if that is there, that is well and good. You can place your stent extremely well. If you don't have a angio registration, where do you place the stent? How do you localize this? You look at the OCT marker here, lens marker. This black one which you see, that is the spot where you are starting to screen the lesion when you are running the OCT. So that spot is your distal spot. You land your stent there and probably come 38 millimeter, so you will cover the entire lesion. This is how you do when there is no angio registration. So that is what I have used. You see here I have used the lens marker and placed a stent there. And if there is angio registration, like there is in a center like us where we have angio registration, that's not a problem at all. It is very easy. And it was post dilated. And we knew that the EL to EL diameter from the mid to proximal was around 4.4. So I have used a 4 size NC balloon and I have post dilated. And proximal EL, we know that it is 4.4. So again, still I have used 4 NC balloon in that area and dilated. And this is the angiogram which we get. So after stenting, you see here, there is a reasonable stent expansion. I have used a 4 size NC there. And after this dilatation, there is, you look at this distal part of the stent and even in the proximal segment. So there is some haziness in both the edges. So in the proximal as well as distal. So for educative purpose, what I have done is we have taken multiple views. You look at this angiogram. This is what generally what we do when there is no imaging. So proximal segment in the angio, there is haziness. Even here, there is some haziness. And you come there, you down here and there, both in different views, you can see that there is some amount of haziness. So if this is the scenario, generally we take multiple views and we try to see whether it is whether there is a dissection or is it a thrombus. So, and there is a lot of dilemma. So generally what I do is, if not for educative purpose, I will never take so much of shots. After the stent post dilatation, if the flow is good and if I feel angiographically stent is expanded well, and then we go ahead with a optical coherence tomography. Advantage is you need not take multiple views. We can see this OCT clearly shows, see at the distal part now where the stent started, there is no dissection and there is no any thrombus there, and stent is well opposed and there is absolutely no dissection. OCT is very, very sensitive to pick up dissection. And of course, it is absolutely there is no dissection. And then you look at the stent expansion here. It is a well expanded stent. And you can look at the proximal area also when the run comes there. And there is no dissection or thrombus. But probably for some reason, there is some haziness on the angiogram. Probably it is spasm, or if it is probably a mismatch, you can call something. But definitely imaging wise, there is no major problem. So you can get an idea of post stenting also with just one run of OCT instead of taking angiograms in different views and then come to a conclusion. There is definitely no dissection. So we can go ahead with this procedure without doing much of, without any worry. And same patient had some amount of plaque prolapse here. Plaque prolapse is, that is after stenting, it's very common in acute coronary syndrome. Even in chronic stable angina, you can get, if the plaque prolapse is less than 20-30%, when it is very minimal, you need not worry, you can just leave it. If it is significant, reducing flow, or if the plaque burden is more than 30-40%, probably you can try to balloon that area. And now you look for stent expansion. As our European guidelines, we are sure we must be aware that when you stent a vessel, you should try to get at least 80% of stent expansion. compared to the reference area. So here, the distal segment, we have got an expansion of 94% compared to the distance reference area. And here in the proximal segment also almost 90%. So if at least 80% is there, that means it is a good stent expansion, and your minimal stented area is very well acceptable. But sometimes if this expansion is lesser, probably you will have to take a bigger balloon and dilate. But when you are taking a bigger balloon, never exceed the size of the EL to EL. If you exceed that, your chances of dissection and rupture is very high. And probably use a NC balloon to the maximum size of EL to EL. Don't go beyond that. But in spite of doing that, if you are not getting an expansion, and then probably you will have to accept it and then come out. And if that area, if it is at least an area of around 4 or so, 4.5, then probably we can accept and come out. But sometimes in the distal area, if the vessel is small, and if you feel that plaque burden is more than 50%, and your stent expansion is not adequate, your expansion is around 50-60%. But in such cases, probably you will have to consider putting one more stent there so that you get a better expansion, and your stent expansion is fine. So these are some of the points which you should remember. And in a case with diffusely diseased LAD who came with an acute anterior wall MI, this is how you use an optical coherence tomography OCT for selecting a safe landing zone, getting good result, and of course getting better MSA so that your long-term results are better. And another acute MI, this is a common scenario. After an MI, after thrombosection, this is the angiographic finding. There is a plaque there around 60, 70% or 80%, you can call whatever it is. So whether you want to stent it or not, if you want to know the etiology of this acute MI, you look at this OCT. There, that area narrowed point, MLA is only 1.47. If area is less than 1.9 in most of the studies, if it is less than 1.9, definitely there is no doubt it's a significant lesion. You should go ahead and stent it. Not only that, if the area is more than 1.9, but if you have a doubt, you look at the morphology or the etiology of the MI. Here, it is a very clear ruptured plaque which has caused this MI. If there is a rupture, probably I think you should go ahead and stent this patient, and he does not benefit with just medical management. So this patient went ahead, dilated and stented here. And he has got an excellent stent position. And of course, we have 3D modes where you can confirm the stent expansion, look for dissections. All those things are very useful. And this is a fly-through mode where you get very clear. If there is a white color in the stent, that indicates it is good. If there is red color, indicates it's malapposed. So automatically the machine itself indicates, and then depending on that, you can take your further decisions. And this is the final check angio. You look at this case, this patient also came with an acute inferior wall MI. This is the angiogram. So when you get an angiogram like this, most of the time we are very not sure whether to stent this patient or not, because probably it is only a thrombus, or is it rupture, or is it erosion, or is it calcific nodule. We are not very sure with just angiogram. And today decision making after acute MI is also based on imaging or pathogenesis or the pathology of this lesion, not only an angiographic finding. Here, you look at the OCT, here this patient had probably looking something like a rupture there. And of course, luminal area was also lesser. And there was a lot of thrombus. Keeping all this in mind, I had to go ahead and stent this patient. And with confidence stented and post-stenting, it's an excellent result. So that is how you take a decision in acute MI today. You should look at this similar anterior wall, similar acute MI, but anterior wall MI. Patient underwent a thrombosection, and after thrombosection, this is the angiogram here. It is looking like almost recanalized or so. You look at the close-up area here, there is some haziness in this part. So what is the reason for acute MI in this patient, an young fellow like this? OCT clearly shows, this is the OCT run. It clearly shows there is no area of rupture here. I could see areas of thrombus there and some areas of irregularity. Probably this is an erosion here. So this is how the erosion looks in OCT in an acute MI. Today, after this erosion study, in most of the time, and if the lumen area is also adequate, there is no need for stenting. These patients can be just left on antiplatelet drugs and followed on medical management. And follow-up, they have excellent results. And 1 month follow-up or 3 months follow-up OCT shows excellent resolution of the lesion. So here clearly this is a case of erosion without any rupture, and we can just live with confidence without doing anything. And coming to left main, we are all very familiar for distal left main. OCT is very useful, and there is always a controversial, or probably it is still not a standard imaging left main ostium under OCT. So what happens is there are certain techniques which you can do, and even the American Heart Association and European Society says that almost 80% of the time you can look at the left main ostium, but 20% of the time you may not be able to see the left main ostium. So in such cases, how to use OCT, and at the same time, there are certain technical modification which we can try. See, this patient had significant strong positive treadmill. There is a ostial left main disease, not very clearly picked up on angiogram, very doubtful. Look at this area, there is some ostial narrowing, and there is some amount of reflex is there, but still it is not good reflex. There is pressure damping, and there is a suspicion of left main ostial disease. And next step is I have done a FFR. FFR is positive, it is 0.74. So then probably there should be a significant left main disease there. Then what I do is I have wired both LAD and LCX, and to image the ostium of the left main, there is a separate technique. What you can do is, there are many techniques. This is one of the techniques which I follow. You can keep one wire in the ostium of the cusp of the aorta, and then you keep the guide very near to the left main. You need not engage it, just direct the guide towards the left main, and you can use a power injector, or if you are injecting by hand, increase your force of injection or increase the PSA and flow rate in your injector, and then you get an acquisition like this. See, the problem is when you get like this, you may not be sure where the ostium of the left main is. Even if you have an angio registration, there might be doubt. To confirm that, if you can see the third wire, see here, there is the third wire seen here, 1, 2, and 3 wires. If you see the third wire is floating in the cusp of the aorta. That means you have crossed the left main ostium and you have come into the aortic cusp. So that gives an idea, and you can get a clear imaging of the left main ostium in this. So this is called the hanging third wire or the hanging wire in the aortic sinus to navigate your OCT catheter there. And of course, then position the left main stent, stent there, dilated. And then, of course, one more important thing you should know is, to know the diameter of the balloon for NC, you should know the EL to EL of the left main at the ostium. Sometimes, if you are unable to see the ostium very clearly, what you can see is, you can see the area just after the ostium that will be seen well. You look at the EL diameter at that area, take a balloon, NC balloon to that diameter, and you go ahead and dilate, then you will get a very good apposition. So in this case, at that stented area just before the ostium, the EL is almost 4.86. And near the ostium, it is nearing 5. So what I have done is I have taken a 5 size NC balloon and dilated, and excellent results have come. And if you have any doubt, you can always reconfirm with an HYBIZ. See here in this patient, the HYBIZ, the ostium is well opposed. And this is the beginning, probably when you are not sure, you want to see the ostium of the left main, you can use this. Otherwise, there is no need of this HYBIZ. You get familiar with OCT itself. And coming to nodules, calcific nodule is a notorious thing in treatment. So in this patient, he had a ACS, and again, you see this is the angiographic finding. So this was in probably some 3-4 years back when we were treating these cases, and we started our OCT. We had not concentrated much on this OCT finding here, but actually this is the calcific nodule. We had missed it, but anyhow, we knew that there is a calcium there, but it's a difficult case. And at that time, what we did is we just ballooned these lesions. We got that some area and we deployed the stent there. And after deploying the stent, you see here, if you are just leaving the calcific nodule, whatever you do, you will never get an expansion of the stent in that area. See, the stent is always expanded, and then the nodule nearby here is not allowing the stent to go and get opposed to the vessel wall. So, and there is areas of malapposition, and this is the problem you get. And you see this calcific nodule is just there, and the stent is going up beyond that, like that, and there is significant malapposition. So when you, but angiographically everything was fine. In spite of putting a very high pressure balloon, we could not do. But ideally, when you see a calcific nodule, the best thing is to use rota or at least very high pressure OPN balloons. So similar case, a significant calcified lesion. We started off after OCT with rotablation. And once after rotablation in the calcific nodule area, I have used a OPN balloon at high pressures, 35 atmospheres. And then after that, you see OCT, how it looks is, this is the calcific nodule which is shaven off. When it is shaven like this and the balloon dilates, then you can easily compress and then probably you'll get a better stent expansion in a calcific nodule. And there are certain things to make out, how to make out spasms. We'll go through the next cases, 1 or 2 cases. And here, even here, this patient had left main disease. So I have placed a stent in the left main, a long stent placed from the left main ostium till the middle AD and then dilated well. And we measured stent expansion, and we used that OPN balloon or NC balloon for that stent expansion, depending on the EL diameter. And the EL was around 4.8. So I have used a 5 NC balloon at the ostium of the left main with getting a good result. Angiographically, this was the final results in this calcific nodule patient. And one more interesting case is, do we have time? Can I just finish this last case? This patient had an acute MI elsewhere, and one of my friends treated this circumflex vessel. And after stenting, 6 to 7 hours later, he had again a stent thrombosis. And once, hello, there is a lot of disturbance. Somebody's mic is on, please. So, yeah, correct. See, after an acute MI, he had a stent thrombosis. So he did some thrombosection in that stented area, and then this was the angiogram he got. Angiographically, you could not see what is the reason for stent thrombosis. And this patient being a VIP, he was referred to me for imaging. And then I did a OCT. In the OCT, this is what you see. See, after the stent, there is a clear-cut area of significant dissection, severe dissection here. And there are areas of malapposition. And you have areas of underexpansion. So these are the findings in a patient, one single case of stent thrombosis, multiple reasons, dissection as well as malapposition and underexpansion. All the 3 was present. And then this final check, this patient underwent 1 more stenting and post-dilated. And then this is the final result what he got. And this is an advantage of using OCT. And of course, we have other lot of varieties like bifurcation, which I think Davidson will talk to you, and calcified lesions. Probably if in some other occasion we can discuss those cases. I think with this, I will stop here and we'll go for discussion. Thank you.
Thank you very much. Thank you very much, Dr. Salamani.
Yeah.
For showing nice cases and showing in ACS, the use of OCT in ACS and how to optimize the stent implantation. Now we move on to, we'll take the questions at the end of the, I don't have any questions at this point of time. At the end of the webinar, we'll take questions. Sure. Now I'll ask Dr. Deepak Davidson to talk about OCT in bifurcation. Good evening, Dr. Davidson. Go ahead with your talk.
Good evening, sir. Hello.
Yes, Deepak, you are audible.
Yeah, Dr. Selvamani, it was excellent. It was a very lucid presentation. We all enjoyed your presentation. Well, can you see my screen?
Still, we are not seeing Deepak. You have to start share screen.
Yeah, I've started sharing it.
No, actually, there are two buttons. Press the bigger share, full share.
Yeah, I've done that.
But your screen is not visible.
Okay,
Yeah, we
now,
can see. Yeah,
now I hope you can see me.
yeah. Now we can. Yeah.
Yes. First of all, let me thank Sujata Madam for this venture. As well, let me thank Team Abbott also for having given me this opportunity to be with you all this evening. In the next 20 minutes, I shall share with you the usefulness of OCT in bifurcation stenosis. I shall start with a case history. This was a 60-year-old gentleman who presented with class 1 effort angina. His treadmill was positive, and so he was taken up for angiographic evaluation. I hope you can see the images. The spider view was the first view that I saw. This particular angio was done by a colleague of mine, a junior one. And as soon as I saw the first image, I was horrified. I felt that it was the catheter, the diagnostic catheter that was moving in and out of the left main. I thought that it has dissected the distal left main. And in the cranial view, you could see that there is some significant disease at the left main bifurcation with a speck of calcium over there. So initially we felt that it was a dissection with some amount of contrastasis over there, but we waited for a while. However, later on we found out that it was not the dissection as such. So because all the other vessels were normal, we thought of doing an image guided angioplasty for this particular vessel. In the first image, you could see that there is significant amount of calcium there involving both the LAD as well as the circumflex and the left main bifurcation. In the second image here, you could see that there is some shelf-like projection at the left main bifurcation, something protruding into the bifurcation, suggestive of some dissection flaps. So we decided that definitely we should do image guided PCA to make sure that what exactly is happening over there, even though we were sure angiographically that there was some amount of calcium over there. Now, how does OCT help me in doing bifurcation angioplasty? While I start off with the procedure, OCT would help me to identify the plaque morphology, whether it's a calcified lesion, whether there is a soft plaque, am I going to have a significant plaque prolapse, will I get a proper stent expansion? These sort of information I would get with a pre-procedure OCT, the first run. It also would give me an idea regarding the ostium of the side branch, the measurements like the length of the stent, the landing zone, the EL to EL diameter of the vessel, such sort of information I would get. As well, I would get an idea regarding the side branch compromise following the main branch stenting. Once I stent the main vessel, am I going to compromise the side branch? These sort of information I could achieve with the help of the OCT evaluation. This is the sort of image one could achieve with the help of a 3D OCT when you look at the side branch ostium. Now, there are three predictors that would tell us whether I'm going to lose the side branch following the main branch stenting. First thing would be an eccentric plaque on the opposite wall of the side branch. When you deploy this stent in the main branch, there is a chance that you are likely to shift the carina and you can compromise the side branch. The second important point is the carinal angle. Here you could see the carinal angle. When it's a narrow carinal angle, there is always a chance that you can push the carina to the side branch and the side branch can get occluded. And the third important point is the BPCT length, the branching point, which is denoted by the red line over here, to the carina tip, that is denoted by the green line. So the distance from the branching point to the carina tip would give you an idea. If it's a very short length, then you are likely to close the side branch. So this is the data that says that when you have a carinal angle that's less than 50 degree, you are likely to shift the carina, you're likely to lose the side branch. And second important point, when you have a BPCT length of less than 1.7 millimeters, again you are likely to lose the side branch. So these are the informations that one could get with the help of an OCT while evaluating the bifurcations. Now coming back to our patient, this is the first run from the LED back into the left main. If you could concentrate here in the short axis, in the cross-sectional view, you can see at 3 o'clock position there is significant amount of calcium. At 6 o'clock position, now you're seeing significant amount of calcium. I can show you the frozen images also. That's the 3 o'clock position that shows us that there is a calcific nodule at the left main bifurcation. You can also see in this image that there is a huge calcified nodule at the 6 o'clock position, and at 8 o'clock position you can see where the green arrow is, that's the circumflex origin. So we saw that there is a couple of calcified nodule, and the circumflex ostium is also clearly seen over there. So this is the 3D OCT, which gives us an idea regarding how the left main bifurcation looks like. You can see here that it's a slit-like opening of the circumflex. Initially, by looking at the angiography, we had a feeling that there was a shelf-like projection at the left main bifurcation. So we might find it difficult to wire the circumflex artery. But by looking at this 3D reconstruction with the help of OCT, you could see here that the circumflex ostium, it's a slit-like opening. There is nothing shelf-like over there, and you are seeing two calcified nodules on either side of the circumflex ostium, which makes us feel that we might not find it very difficult to wire the circumflex artery. So that's the different view of different 3D view of the left main bifurcation, wherein you can clearly see two nodules protruding at the left main bifurcation and compressing the circumflex ostium. So that's the sort of information that you could achieve prior to procedure when you do the first OCT run. So because there was significant amount of calcification as well as nodules, we did rotablation of the bifurcation into LAD as well as into the circumflex. Rotablation into the LAD was not challenging, 1.5 bar at 180,000 RPM. However, crossing into the circumflex was challenging. You could see in the second image that the guide catheter is backing out, and following that, finally we were able to route of the circumflex ostium, the calcified nodule. And in the third image, you could see that the guide catheter is repositioned in such a way that you could get a better cut at the bifurcation. So if you look at the two circumflex rotablation, images, you could see that in the first image, we have the position of the guide catheter is from above downwards, and the second image you could see that the guide catheter position is below upwards, so that we could get two angles of cut at the bifurcation of the left main. Now that's the image following rotablation. You could see that there is a burrow created in the calcified nodule over there, which can be identified with the help of this pink arrow. Now, once we did the rotablation, we took angiosculpt, that was a 3 millimeters angiosculpt, and dilated the LAD as well as the circumflex ostium. And following that, we went ahead with stenting. Our plan was to do a DK crush stenting. So in the first image, here you could see that the stent is positioned at the circumflex with a balloon in the left main. The stent was deployed at high pressures, and following that the balloon was removed, and then the stent was crushed, and following crushing of the stent in the circumflex ostium, we tried to cross into the circumflex branch. Now it's recommended that when you do a DK crush stenting, when you try to cross into the circumflex, it should always be in the proximal cell rather than in the distal cell. If you go through the distal cell, you are likely to go between the vessel and the stent, and so it's recommended that one should try going through the proximal cell. So that's the wire going through the proximal. We were trying to get through the proximal cell into the side branch, and once we got into the side branch, we did the next OCT run from the LED back into the left main to see where exactly the wire has gone through. You could see in the longitudinal image down there that there are two cells over there, and the wire from the left main has gone through the proximal cell into the side branch, which could be better appreciated in this particular 3D reconstructed image. In the 3D reconstructed image, when you do stent rendering, many a times while doing the DK crush technique, you won't be able to see the rendered stent because many a times the stent that is protruding into the left main is very small. You just need 1 to 2 millimeter protrusion in the left main. So the computer wouldn't identify that as metal over there. So stent rendering may not be possible. So what you're seeing here at the circumflex ostium is just the ghost images of the stent cells. And you could also see clearly that the wire has gone through the proximal cell into the side branch. This is just another example of a DK crush of following crushing. You could see that the wire has gone through the side branch, through the proximal cell into the side branch. It's just to highlight the fact that while doing DK crush technique, you may not be able to do stent rendering following the crushing of stent because you do not have huge amount of metal in the main vessel. Now, this is one scenario wherein we had lot of stent metal crushed in the proximal vessel so that we could have a proper rendering of the stent. In this particular situation, you could see that there is LAD bifurcation stenosis. You could see the stent being positioned there. When the stent is positioned, it's positioned in such a way that the stent is almost 5 to 6 millimeter into the proximal LAD, which means that there is a significant amount of metal that's going to be there in the proximal LAD, and those 5 to 6 millimeter is going to be crushed. So that's the stent being deployed, and following that, around 5 to 6 millimeter of stent was crushed. So that's what you're seeing there. Now, following that, we try to recross into the side branch, that we try to go through the proximal cell, and then we did a OCT. Now here you can see the rendered stent. Initially you are not seeing that. Here we were able to see the rendered stent because there was significant amount of metal in the proximal left anti-descending artery. Just to highlight the fact that when you routinely do a DK crush technique, you may not be able to see the stent properly at the side branch ostium when you crush it. In this scenario, it's just to highlight the fact that the stent, the amount of stent in the metal in the proximal vessel was significantly more, so that you could see the stent that is crushed to the proximal LAD wall, and the wire is going through the proximal cell into the side branch. That's what is recommended. And following that, the DK crush technique was done, and rest of the steps were completed. And that's the image low down there. You are seeing that we could achieve a good flow in the LAD and diagonal branch. Now, coming back to our patient, so we try to cross into the circumflex through the proximal cells. Then following that, we try to do the stenting. You could see here that okay, we did the first kissing balloon dilatation, and following kissing balloon dilatation, we did the stent implantation from the left main ostium in the left anterior descending artery, and that's following the stent deployment from the LAD left main into the LAD. And the next step is to again go into the side branch. Now, in the past, it used to be recommended that the second recrossing also should be through the proximal struts. However, nowadays it's recommended that the second recrossing probably one should try to go through the distal cells. So you're seeing two images. The first image, the wire was getting into the side branch through the proximal cell. So we took it out, we tried to go distally, and the second image shows us that the wire is going through the distal cells into the side branch. And following that, we did the kissing balloon dilatation, proximal optimization with a 5 millimeter balloon, and angiographically you could see that the image is looking good. There is good flow in the circumflex as well as the left anterior descending artery, and this is a 3D fly-through image that makes us understand that the side branch is looking good. There is no significant amount of metal at the carina, and this image again you could see here that that's the 3D reconstruction of the bifurcation. The stent is well opposed, the circumflex ostium is looking very clean, and you could see a very small metal carina at the left main bifurcation. However, it's not obstructing the flow into the circumflex artery. So these are the information that one could achieve with the help of optical coherence tomography while doing a bifurcation stenting. So you get an idea regarding the wire position following recrossing, whether you have gone proximally, whether you have gone distally. You could also get an idea regarding the stent cell parameters. You could identify whether you're going to have a poor long-term outcome following kissing balloon dilatation. This is how a normal stent would look like. You have a lot of crowns there. You have also the links coming there. The links is denoted by the green arrow, and the crowns are denoted by the pink arrow. Now you can have a free carina, or you can have a link at the carina. Now in the first image, The distal portion shows that there is no link at the carina. And the second image, you could see that there is a link at the carina. Now here again in these images, you are having a link at the carina. The first image shows us that there is a link at the carina, and the second image shows us that it's a free carina. There is no link at the carina, which means that in the second image following kissing balloon dilatation, you could get a better stent apposition compared to the first image. First image, you are having a link sitting there so that uh, the apposition of the stent following kissing balloon dilatation may not be perfect. Again, if you see the first panel, in the first panel, there is no link at the carina, and following kissing balloon dilatation, the side branch ostium looks excellent. In the second image, you could see that there is a link at the carina. However, following kissing balloon dilatation, it's a suboptimal stent apposition. So these are the information that one could achieve with the help of OCT following a stent implantation across the bifurcation. And we also have small data that suggests that when you have a linked bifurcation, the stent apposition is not going to be great. But then all these things that one should also keep in mind that all these things are done after the stent implantation, and you do not have a real control over whether you are going to have a link at the carina or whether you are going to have a free carina. Now, this is another patient, an elderly gentleman who presented with a recurrent rest angina, LV dysfunction, borderline hemodynamics, taken up for a left main bifurcation angioplasty. Because the circumflex was dominant and a huge vessel, we decided to stent into the circumflex from the left main. And following that, that's the flow into the circumflex. You could see that the wire is inside the left antidescending artery. Now, when you want to wire into the left antidescending artery, one should always try to achieve a wiring through the most distal cell, because based on this images seen there, if you try to go through the distal cell following kissing balloon dilatation, you can have a proper scaffolding of the side branch ostium rather than going through the proximal cells. So we crossed into the side branch through the distal cells fluoroscopically and did an OCT evaluation. And here in the longitudinal image down on the screen, you could see that across the LED ostium, there are two cells, a proximal cell and a distal cell. And you could see that the wire that is coming from the left main has gone through the distal cell into the side branch. So that is what you need to achieve, which can be better made out in the frozen image with the yellow arrow. Now, this is the 3D reconstruction of the wire going into the side branch. You could see that there are two cells there, the proximal cells as well as the distal cell, and you could see that the wire has gone through the proximal cell. So that's the greatest advantage of using an OCT during a bifurcation stenting. You can clearly see where exactly the wire has gone through. You can also remove the wire and rewire if you have gone through a proximal cell wherein you want to go through the distal cell. So that sort of information could be achieved with the help of OCT, and those are the images following the tap stenting, and you could achieve good flow in the LED as well as the circumflex artery. At times, the wire which has gone into the side branch, it would have gone through a very narrow cell into the side branch. And because this has gone through the very narrow cell in the side branch, this might not let you push the balloon into the side branch. This was one scenario wherein we had a difficulty in getting the balloon across into the side branch, which was identified with the help of OCT. This was a left main trifurcation disease. You could see that there is disease at the bifurcation, there is disease at the ramus, which is a huge vessel, as well as the left antidescending artery. We tried to convert it into a bifurcation and did a DK crush technique. So we wired LED and ramus, we dilated it and stented the ramus, which was crushed with a balloon in the left main. And following crushing, we crossed into the side branch, did a kissing balloon dilatation, then did a stent implantation from the left main into the left anterior descending artery. So that's the stenting being done. And following stent implantation, following POT, we tried to go into the side branch. Now we were able to get into the side branch. You could see that the wire was going with little bit of difficulty in the side branch. However, none of the balloons would go into the side branch through the through over this wire. So we decided to see what exactly was happening. So we did an OCT evaluation, and here in this image you could see that the wire has gone through a remote cell into the side branch. You could see that there is a small cell up there, and the wire has gone through the small cell into the side branch, and that was the reason why the balloons wouldn't go into the side branch through this small cell. Now if you see this frozen image, if you see the arrow, you could see there that there is a big cell down there. Probably the wire should have gone through that bigger cell into the side branch, and we would have found it easy for our balloon to go in into the side branch. So what we did was we took out the wire and rewired it, and the wire went somewhere else. Later on, we were able to get the balloon in the side branch. We were able to do the second kissing balloon dilatation, proximal optimization, and we were able to achieve a good flow inside the vessels. Now, this is one important thing. When you get stuck during your procedure, you do an imaging, you identify what exactly is happening there, what exactly is the problem there. You might be able to overcome the problem. Now, following stent implantation, when you do an OCT evaluation of the bifurcation, you can get an idea regarding the ostium of the side branch. You can evaluate the carina, you can look for plaque prolapse, and you can also evaluate complications. Now, this was a patient who presented with an lateral wall myocardial infarction. His diagonal was occluded. We're not bothered about that. We wanted to fix the ostial LED critical stenosis. We did multiple imaging. We were not able to clearly identify the ramus ostium as well as the circumflex ostium in none of the images. So we were not sure whether there was significant disease of the ramus as well as the circumflex ostium. Because it was an acute MI, we prefer using HYBIZ evaluation. We did an HYBIZ run pullback from the LED back into the left main. We found out that the ramus ostium was free of disease, which can be seen here. Then we also did a pullback from the circumflex, again made out that the circumflex ostium also was free of disease. So we identified that the ramus ostium was clean, the circumflex ostium was clean. So we decided that we would go with a single stent strategy, wired the ramus with a run through wire, and dilated and stented it. Following proximal optimization, you could see that the flow in all the vessels are good. However, you are not clearly seeing the ostium of both these vessels. So we did an OCT to see the ostium of these two vessels. You can see here that the ramus ostium as well as the circumflex ostium is seen clearly in the OCT imaging. You can also see that there is some crowns across the ostium, but there is no link over there. So this is just to give you an idea regarding following a bifurcation stenting. You do an OCT, you get an idea regarding what exactly is happening at the ostium, whether there are any links, whether the ostium is looking good in situations where angiographic results are not really satisfying. Now, this was a patient who had undergone an left main to LED stenting long back. He came with an acute coronary syndrome, and you could see that the diagonal ostium has got significant disease. And the stent in the LED, which was a prime, that was a science prime, long stent, which was looking good after 4 years of implantation there. So our plan was to do a tap stenting of this diagonal branch. So we wired the diagonal branch, dilated the diagonal branch, and that is a tap stenting done. Now you could see that that's the final result, and it was interesting to see the OCT images following the side branch stenting. By tap, we need that we mean that we need to have one strut protruding into the main vessel. Here in this OCT image, you could see in the lower longitudinal image that there is one cell protruding at the bifurcation into the main vessel. This is the advantage of doing a tap technique. You will not miss the ostium of the side branch. This is more interesting. You could see the 3D image of the bifurcation, that herein you could see that there is one cell that is protruding, one crown that is protruding into the main vessel. The advantage of doing a tap technique over a T technique. So this information, you'll be at the end of the day, you'll be happy that you've done a good job for this particular patient so that he doesn't come back with a restenosis in future. Now I'll stop with two cases. Two DK crush technique, one done in 2018 and one done in 2019. In 2018, it was recommended that one needs to do both the recrossing into the side branch through the proximal cells. And this is what we saw following the stent implantation. In this particular patient, he had a dominant L6, he had a large LED, he had significant calcium at the left main bifurcation. So we went ahead with rotablation of the LED. LED rotablation was difficult. We were able to do that with an 1.5 millimeter burr. circumflex rotablation was even more difficult. Patient had brady. It was a dominant circumflex, slow flow bradycardia. We had to push in a temporary pacemaker, and finally we were able to do the rotablation of that particular circumflex also. And following that, you could see that the stents are being deployed. Here again, one should keep in mind that it was done in 2018, and both the crossings into the side branch was done through the proximal struts. That was a recommendation at that point of time. The European Bifurcation Club recommended that one should try to go through the proximal cells. Here the OCT images shows that the wires are going through the proximal cell into the side branch. And following the stent implantation and optimization, you could see the final result. Angiographically, it looks perfect. The circumflex is looking good. The LAD is looking good. Flow in all the vessels are good. However, when you look at the longitudinal image low down there, you could see that there is a huge amount of metal carina which is protruding into the bifurcation. So this happened just because both the crossings were done through the proximal cells. So we pushed huge amount of metal onto the carina, and that's the metal at the carina which makes us understand that probably we shouldn't be doing a proximal recrossing the second time when you do a recrossing. So when you do the first crossing, probably it has to be proximal recrossing. And this is the 3D image which shows that the flow in the ostium of the circumflex is looking good, but then the bifurcation, there is huge amount of metal sitting over there. 2 years down the line, the patient is doing well with no much of problems over the bifurcation. And now coming to the last case, this was a DK crush technique that was done almost a year back. Here what we tried to do was we went through the proximal cells in the first crossing, and when we did the second crossing, we went through the distal cells. You could see here in the lower image that this was an young chap post bypass surgery. 1 year down the line, all the grafts were occluded. He came back with recurrent rest angina, hypotension. He was taken for a bifurcation stenting, and in the lower image you could see that the second recrossing through the stent cells, it's done through the distal vessel, which can be clearly seen that the wire is going through the distal cells into the side branch. And following all the steps of bifurcation stenting, you could see that the bifurcation is looking good and the carina itself is looking good. As in the previous case, you are not seeing significant amount of metal at the carina. So probably this is how we should be doing a bifurcation. When you do the recrossing into the side branch, the first crossing probably should be through the proximal cells, and the second crossing should be attempted through the distal cells, so that the carina would be looking good. You wouldn't have a huge amount of metal at the carina. So these now again in this particular patient, we found out something more. The left main ostium, there was some stent deformation due to the catheter. You can see that clearly. The catheter had hit the ostium. Many of us, we feel that the ostium cannot be seen with the help of OCT imaging, but then you could see here that the ostium of the stent can be very clearly seen, and you could see that there is a crushing of the stent over there. So finally what we did was we took another 5 millimeter balloon, and then finally again we did a proximal optimization, and those were the results. You could see that in the first image, the flow in LAD and circumflex was not good. Patient was having recurrent angina, hypotension, but finally following stent implantation and optimization with a 5 millimeter balloon, you could see good flow inside both the vessels. So those are the informations that one could achieve while using OCT for bifurcation stenting. OCT always gives us better understanding of bifurcation stenting and identifies complications more precisely. More importantly, you can identify, you tend to know there are situations wherein you are happy at the end of the day seeing the OCT images, but there are situations wherein you understand that whatever you have done is not good. At least you need to modify a technique the next time. Thank you so much.
Thank you, Dr. Davidson. It has been an excellent presentation. And we have some change in the schedule because Dr. Barwa, who was supposed to give us a talk on his case, has some logistic problems. The internet is not working. So our Dr. Salmani is going to talk on stent thrombosis later. But before that, I would like to take a few questions from our participants. So I'll take the first question. So if we are calculating the thrombus or plaque burden in a single frame through manual multiple point markers, will it give accurate stenosis rate?
Yeah. See, can you hear me?
Yeah, go ahead.
Yeah. See, actually, on an OCT, how you calculate the area stenosis is the outer, that is, the inner lumen, the machine itself recognizes. Only the outer area where the block starts, that is what you should mark. Without marking that, we cannot get the percentage of stenosis as of today's software. And I think that is almost correct. It is not a problematic issue. And the current technique, that is what we use, and it gives a correct area stenosis.
So the next question is also from Dr. Krishna. So
That is, first you will have to mark the EL, and then once you get the EL diameter, then the lumen diameter automatically the machine takes.
So the second question is, if you are doing a patient with acute coronary syndrome with thrombus, so what are the parameters or criteria you are following for thrombosuction and stabilizing the patient before doing a stenting, before PTCA? That's what he said.
Yeah. See, it is a very important and interesting topic where he says it when you stent or when you don't stent. It is something like that. Or when you are stenting, what are the precautions you are getting? So most of the time, you see that today's indication for stenting is if the lumen area is less than 70%, or if it is a ruptured block in that area, or if it is a calcific nodule, probably you will have to stent definitely those patients if possible, unless otherwise. Where you need not stent in an acute coronary syndrome is basically erosions, where you're definite that there is no plaque rupture, and lumen area is somewhere around 70% or borderline. Definitely you need not stent those patients. You can put them on medical management. And similarly, recanalized thrombus or and then that is spontaneous dissections, coronary dissections need not be treated unless there is hemodynamic instability. These are general indications for stenting and not stenting. But when you are about to stent, there are certain things you should see. But for example, if you are not getting TIMI3 flow in spite of thrombosection, doing whatever you like, then I have an hesitancy to stent immediately. And of course, there are studies like deferred stent where they have stented probably 18 hours later or pre-discharge. They bring back the patient to cath lab and then they stent. All those trials are still controversial. But my way of practice is if the flow is less than 2, TIMI2 flow, and if it's a huge thrombus burden, generally I don't stent. I try to put them on anticoagulants or GP2B inhibitors and try to bring them back later. That is my criteria. And I think,
I would also agree with you. When you have a very young patient, angiographically following thrombosuction, you make out that there is good flow in the vessel. There is just you do not have a critical stenosis. When it's only an intermediate stenosis, do an OCT. If you don't see any significant plaque rupture, if the plaque seen there is not a very vulnerable plaque, if there is no significant amount of lipids over there, an young patient, most probably it's going to be a plaque erosion, and you can always defer that. That's what we've learned from the erosion trial, that at the end of 1 month, most of these patients, they do not have significant stenosis when they were taken up for a check angiogram.
Yeah, thank you. That means we are talking about acute coronary syndrome where the diameter stenosis and all those things, they do not matter after balloon dilatation and thrombosuction and all those things. Probably what we are saying is if you do an OCT, which is a good tool to differentiate between erosion and rupture. If you have a rupture, stent it. If you have an erosion, leave it alone. That's probably the point you are trying to make. In the next question is, in ostial left main, what is the length of the stent that is allowed to protrude into aorta? Which is considered okay? That's the question.
there is no specific length as such that you should leave. Try to be very precise, but hanging a little bit of extra 1 or 2 millimeters in the ostium is not a problem. It is not going to change your long-term outcome. But probably if you want to re-intubate, or probably when you re-hook that area, stent protrusion might create a problem. You can damage the stent. But most of the time, try to stick to the ostium. But many times it is not possible to exactly place it in the ostium. In such cases, probably a slight protrusion is acceptable. There is no sizing that it should be so much or so. Many times we have had cases when they come with restenosis, or when we want to recheck, there is an hanging stent in the ostium of the RCA or in the left main, so causing trouble in hooking your guide. And even if you hook the guide, rewiring is difficult. And even if you rewire, probably taking a balloon or a stent again, you'll have to go through the struts and go. These are some of the problems. But there is no clear-cut definition how much protrusion should be there.
Yes,
Yeah,
yes, I would also agree with you. There is no clear-cut guidelines or rules where the stent should be positioned, how much it should be positioned inside the aorta, something like that. It's just a common sense. You do not want to miss the ostium of the left main ostium, so position it at the left main ostium. Make sure that at least one strut is protruding into the left main. The challenge of having an extra strut in the left main is it's not going to trouble the patient anymore. But when you want to have a repeat procedure done, when you want to have a reintervention done, you are always at the receiving end. So it's always good that just one strut protrudes into the left main. And if you have done an OCT and if you have done an IVIS imaging and you're clearly made out that there is no disease at the ostium of the left main, then you can exactly position it at the ostium rather than protruding it into the aorta.
yeah, I agree. Another important point is when I am doing an osteal, aorta osteal lesion, it is important to avoid the chances of LSD, that is longitudinal stent deformation, are a little bit higher. So you end the procedure with an adequate dilatation of the ostium, the balloon protruding into the aorta. It's also important. Then the next question is, what's the role of OCT in IVL?
Yeah, intravascular lithotripsy. Yeah, it is definitely very, very useful. And I have a different technique of using OCT for IVL. But probably next time somewhere I can show those cases. It is very important pre IVL. When you do an OCT, you will clearly know in which area the thickness of calcium is high. What you do is you mark those areas in the OCT on your angio-co-registration, and then you can decide. See, actually the IVL balloon has only 80 shots it gives, 80 shocks. After that, you cannot use it. And if the lesion length is very long, you'll have to decide where you want to give more shocks. So decide that, you do an OCT, select that spot, and then you do extra shots there. For example, where the calcium is less, you can give less shocks. And where there is thickness is more, for example, 700, 800 microns or 1,000 millimicrons of calcium, give some extra, some 10 shocks extra, you give some 20 shocks in that area. And then probably you will get a better results, your expansions will be better. And post IVL also, you can do an OCT. 50% of the time, you can see significant calcium fractures. And 50% of the time, you cannot make out fractures. Probably even if you cannot make out fracture, it will produce micro fractures and it softens the calcium. Probably it helps in expansion of the vessel in that.
So the
Yeah,
next,
very true.
yeah, go ahead, Davidson. You're saying something.
Yes, that's it. When you have more than probably following, when you are planning for a very critical stenosis, it's not so easy to get the IVL balloon inside that. So do a rota. You shave off the superficial calcium, try to get the balloon into the vessel, and identify the area where you have at least more than 180-degree arc of calcium, which is deep inside that. And just a nodule may not, IVL may not help us out. But then when you have a significant arc, when you have a deep arc of calcium, so those would be the area wherein you need to have more of shocks to be delivered at that point. And as Dr. Selmani has pointed out, that we do see microfractures following the following IVL intravascular shock application compared to non-compliant balloon. When you use a balloon and when you use a OPN balloon, many times you see huge fractures. You see huge macro fractures. That's not very common with the IVL technique.
Hello? Am I audible?
Yeah, I can hear you, Dr.
Yes.
Gopalakrishnan.
We lost Davidson for a while. Okay, that means the idea is, if you know that the a significant amount of calcium is suspected, you wire it and then try to get a balloon across. The balloon is not going and the imaging catheter is not going. You have to do a rota or laser, because we don't have laser. You do have to do a rota to get your imaging catheter in, and also following that imaging pictures. If it is an OCT, you look at the calcium, whether it is more than 180 degrees or 5 millimeters depth, a length or less than 0.5 millimeters, depending on the calcium. The calcium is long, bigger arc, then you tend to use IVL, and use the IVL where the calcium is more, because you have a limited this thing. That's what the message is. And then the another question is, what could be the ideal crossing for mini and decay crush? Is it ostial or distal cut? That question has been adequately answered by Dr. Davidson. If you are doing a provisional or a T stenting, you go through the distal strut. If you are doing the decay crush, the first crossing is the proximal crush and second crossing is the distal crush. That has already been answered in the talk. And then the other question, it's a common concern and additional time for OCT. Will OCT run helps reducing angio runs and overall time of radiation exposure? As probably yes, definitely it reduces angio runs if you are well versed with the OCT. With the whole idea of using the imaging is to decrease the angio run, but the OCT also requires contrast. How is the role of FFR in ACS? That's another question. Anybody, one of you can answer that? Dr. Davidson?
Yeah, FFR in acute coronary syndrome, you cannot do it in the infarct related artery. For example, if it's an anterior volume, you cannot do an FFR in the LAD immediately. You can do it in the culprit vessel, but even in that, there are still some controversies, non-culprit lesions, but usually you can do and then decide whether you require any treatment for non-culprit vessels. So that is the application of FFR. And for an acute culprit vessel, there is no role of FFR. You will have to take imaging into account and then probably you look at the lumen area morphology and decide on stenting.
Yeah, the last question is, you do OCT before the stent implantation to make a decision about the lesion assessment and also what kind of stent diameter stent you require. Probably you have very good idea about the length of the stent also, depending on where do you want to if you decide about the landing zones. More so when you have co-registration with you, which is definitely a costly affair. So, and also after doing the stent, getting a good implantation of the stent, OCT helps. The question is, how often the stent diameter decision changes with OCT when compared with angio in your practice?
See, it's a very, very important question. Even in the study, when you take an imaging, the total decision making is almost around 30 to 40% of the time there is change in decision. When you even in trials, Illumin 3, when you compare, but there is a definite change in your decision making when you use imaging. There is no doubt in that. And coming to clinical practice, where it is very, very helpful is to post-dilate the stent. Even initial stenting, for example, you put a 3 stent or 3.5 stent, that doesn't make a big difference. To get a better stent expansion, that is at least to 80% of reference diameter, to NC balloon where you select, to be very, very confident, For example, nowadays I use 4.5 size NC balloons in LED very commonly, which I never used before imaging. 5 years back, we started using OCT for the last 5 years. We had that small machine, then we have this latest integrated machine with us. And of course, before that, we're doing HYBIZ also. Before imaging, I have never used 4.5 size NC balloon in the LED. But today, using 4.5 in LED has become a common scenario with the confidence, because you are definite that it is not going to rupture. You know the EL to EL diameter. It gives a very clear idea. But without imaging, what happens is you are always guessing. You are always undersize. You are very cautious. You are fearful that it's going to rupture. So all those limitations will be overcome with imaging. That is the advantage of it.
Yeah, very true. In the Illumin 1 trial, they made out that in almost 65% of patients, the decision had to be changed, and it was more surprising that in 25% of patients they had to undersize the stent compared to whatever decision was based on the angiography guided decision making. However, that was lumen to lumen evaluation. But then when we at some point of time when we reached the Illumin 3 trial, we identified that probably lumen to lumen may not be good enough. One needs to look at EL to EL. Now, after looking at EL to EL, we find that the IVUS sizing is almost similar to OCT sizing when we go for EL to EL. So we prefer doing EL to EL in majority of situations. Only challenge is distal landing zone. Many times we tend not to see 180-degree arc of normal vessel, wherein EL to EL calculation might be difficult in certain scenarios.
The last question is, are there any new developments happening in OCT?
There are so many new things, software they are updating, and then bifurcation indicators, and then newer software, I just forgot the name. And to assist the side branch size in bifurcation, we have, and then we have an FFR integrated, that is FFR with OCT, it is virtual OCT. All those things are new developments expected in probably another 3-4 years. Yeah.
Are you getting?
You have up to 1 micron size can be seen in newer versions of OCT, but which is still not used available for clinical use. These are all under development and clinical research.
There was a question about, is there any chance of artificial intelligence getting integrated into OCT?
I think it is almost 50% artificial intelligence now. It automatically recognizes lumen, size, vessel, everything. Unlike IVUS, where the moment you get the OCT, all your measurements are ready. That itself is computerized, some artificial intelligence. But beyond that, I think there is all possibility you can have it. What, Deepak, what do you say?
Yeah, very true. In the past, following stent implantation, you need to calculate the stent expansion all by yourself. But nowadays, it divides into 50% distal, 50% proximal, gives you proper expansion. So it's all the amount of time you spend with post-processing, it's not there at all nowadays.
Yeah, thank you. Thank you very much. That's the question so far I have received. Now let's go back to Dr. Salomani's talk on stent thrombosis.
Yeah. Okay, so I will try to be a little bit more precise, and we'll go to the talk now. Are you able to see the slides? Are you seeing the slides?
Yes, we are.
Yeah, very clear.
Go ahead.
The imaging in stent thrombosis is very, very important. Like as you said, that routine today's guideline by imaging, that is OCT, it's almost class 2A indicated in almost most of the lesions. And of course, my feeling is, especially for stent failure, I think it should be a class 1 indication. Probably it will be getting that level in over a due course of time. When you come to stent thrombosis, you see that depends on the day. Stent thrombosis, subacute is between 1 day to 1 month. and late is between 1 month to 1 year, and very late is beyond 1 year. So these are depending on the duration. And of course, you know whether it's a definite, probable, or possible, depending on the angiographic, depending on the clinical scenario. So keeping this in mind, we will go through that. And what are the reasons for stent thrombosis? Is usually multifactorial. One is patient factors, like high-risk patients, when there is resistance to chloride or any other antibiotic. And of course, compliance issues are all there. And device type of stent, size of the thing, whether it is first generation, second generation, type of polymer, type of drug, everything is important. And of course, one is procedure. There is expansion, apposition, runoff, restrictions. These are some of the very important causes. We have no control of this. We have a control of these two things. One is to go for a better product, and of course, you should do a better procedure. So if you do this, thrombosis is going to be very, very less. And depending on the time, usually the early stent thrombosis is all because procedure related. Under expansion, edge dissection, and residual. Late is usually uncovered stents, fibrin deposition. Very late is again hypersensitivity, late malformation, atherosclerosis. These are some of the reasons for stent thrombosis. And what is the main reason for stent thrombosis in many trials? You see this trials, HYBIZ trial this is. So in the minimal lumen area, that is what we emphasize. That is why after stenting, if you are not getting at least 80% of peripheral area, can you hear me? Hello?
Yeah, we are able to hear you, but there is a little bit of disturbance. The audio is not great.
Audio is not clear. Okay. No, it should be okay. See, very important thing is the minimal lumen area. That is, the lumen area is very important. When you do angioplasty, if you are not getting at least 80% of stent expansion and the minimal area of at least on OCT or on an IVS at least 5, then your chances of thrombosis and complication is high. And if there is significant residual stenosis, and if you leave stent edge dissections and huge tissue prolapse, these are some of the reasons why you get stent thrombosis. And then there are different studies which they have gone through this. And most of the time, acute and subacute stent thrombosis is usually uncovered stent or under expansion of the stent is a very important reason. And neoatherosclerosis. Can you hear me now? Hello?
Yeah, but still there is disturbance.
Still audio is not clear.
Now it's okay. Go ahead.
Now it is better. Okay. And of course, very late stent thrombosis is neoatherosclerosis or uncovered stents. So, very important thing is stent under expansion. If you leave it, is one of the important reasons for stent thrombosis. You just remember that. And malapposition, although has not been the main reason in many studies, but significant malapposition, more than 400 microns, is definitely a risk factor for stent thrombosis. Keep that also in mind. And I will just show you some series of interesting cases, what has happened. So this patient, he had underwent, this is a primary procedure that is in 2018 where I have done a primary angioplasty for an acute MI using the biovascular scaffold at that time, that is April 2018. He had a thrombosection, and then the stent was deployed there. And 1 month later, what happened? He came with an acute MI now this year. So at this time, again, he had a totally occluded vessel where I have done a thrombosection. And once I did a thrombosection, this was in the night. So this is the flow which I got. So I got this flow, and in the middle of the patient was also not willing. But I couldn't take much information. So I left this patient this thing, and he was stabilized. He was stabilized for almost 1 month after this. And then he was stabilized for a month, and then are you, or am I audible? Can you hear me?
Yes, now you are audible.
Better.
Okay. So 1 month later, he comes for further workup. At the time I do an angiogram, it looks like this. So it's supposed to go in vessel where this is the BVS area where we have put the TARIS thrombosis, which got relieved this thrombosection. And this is the angiogram. With this finding, I thought the imaging is the solution next. We should go ahead. And this is the imaging image you have. So you have is 3 years old, where you realize there is some amount of promise over there, it is utilized. And then there are areas of unutilized areas, or again, it just towards stretch were there, and some areas of malposition were there, and then some area very minimal. So these are the finding in this patient. And you see this BVS, it is immobilized, but in certain areas, it is not immobilized. In most of the area, it is immobilized. And in many areas, it was significant stenosis also. It was around 60% area stenosis. See, what has happened is it is around 60% here. But keeping this in mind, whether to stent it or not, I did a FFR. Close and relog in. I'll come back. So I'll just come back. I think there is some problem with the audio. I will reload and then again come back to you at this point.
Now we could hear you clearly.
Now you could hear right now.
Yeah,
1 second.
now you are much clearer.
Yeah, 1 second. They asked me to stop sharing, restart again. Your speaker is not working. Please check your connection or use a different speaker. Host has spotlighted your video. Okay. Wait, hold on. Deepak, can you hear me?
Yes, yes, we can hear you, but then in between, there is too much of jarring.
Close what?
Just log out and log in.
For the entire meet.
Yeah, we can do.
1 second. Okay. Log out how? Leave and join. But it will take 2 minutes, Deepak. You can keep discussing something. They have asked me to leave and then rejoin. Until such time, you can discuss something, Deepak.
Yes.
Leave meeting.
Deepak, are you there?
Yes, sir. Yes, sir. I can hear you.
Yeah, go ahead. You want to share any information on the questions we already talked about? So there are two important things which we are discussed today is the imaging, particularly the OCT, was in acute coronary syndrome and bifurcation. You have very well done by you, and also a little bit about calcification and calcium that is also done by you. So these are the areas, and now we are looking at the fourth area where which the OCT is going to help, probably most important area where is there a stent failure, whether it's in the short run or in the long run. So Dr. Salomani is going to talk to us on stent failure in acute stent thrombosis or stent thrombosis. So we have Dr. Salomani back on the screen. You can go ahead, Dr. Salomani.
Yeah, can you hear me, sir?
Yes, yes, go ahead.
Yeah, fine. So this patient, we had to take the help of FFR, and then you see the FFR was significantly positive. So keeping this, yeah, okay. Yeah, 1 second. So keeping this in mind, Is it clear? Okay. Then we had to go ahead and stent it. So this patient, we went ahead and stented with a very long stent from year to year with good expansion and without areas of under expansion. So basically this, the main reason for this stent thrombosis was, that is, areas of malapposition, areas of under expansion, and of course some areas were not endothelialized. These were the reason for this stent thrombosis in this patient. And coming to another interesting case, this patient had undergone stenting to LAD 1 year back in a nearby town. He happened to come to our hospital, come to Madurai, where he had an anterior wall MI in the same area, and he was seen in a local hospital where they thrombolized him. 3 hours after thrombolysis, he was referred to our hospital. So he has a stent. This is the check angiogram 3 hours after thrombolysis after anterior wall MI. 1 year back, LAD stent was put here. So when I did the angiogram looks like this. So generally what we do for such cases, we generally say, oh, it is recanalized vessel. And we ask the patient whether you are taking antiplatelets, or then you reassure and then probably put him on more stronger antiplatelet and send. But on imaging, what happens is, this is what we used to do previously before imaging. But today, after imaging, what you see is, you see significant areas of finding there. There are areas of malapposition, areas of neo growth is there, and inadequate preparation, under expansion stent is there. The maximum area achieved itself is very less. So these are the findings in this OCT in this patient. And you see that there is an area of malapposition in somewhere in the proximal part of the stent, and probably there was a branch there or something like that where it has initiated the thrombus process, and you see that the struts are thickened. Probably it's endothelialized, or it is the residual thrombus sticking to that struts where there is malapposition. And of course, it was totally an under-expanded stent, which required a stent expansion. We'll have to put a bigger balloon, then expand. And this was the area of malapposition. So then what I did is, I did not go and fully expand the stent, but I had to, at least that significant mal-opposed area, I have dilated with a big NC balloon. And after NC balloon, probably a good flow is there, and hope that you will not have further stent thrombosis in that stent. So this is one thing. And post dilatation, it is fully opposed stent there, and I have not done anything much. And after that, this is almost 1.5 years now, he has not come back. And this is what we could do. But what other things I could have done is, I could have put a more bigger balloon, dilated in other areas also, but patient was not willing for further stenting and all. So as a routine thing, only with the NC balloon, only a malopposed area I have dilated and just left this patient. And I have sent him to his own original doctor for follow-up at his own native place. And this patient had almost late stent thrombosis. You see, this is the angiogram after episode of ST elevation in the anterior leads. This stent was put almost 8 to 9 months back. And this is what is the finding. So when you see this, what happens is, in this patient, generally without imaging, we would have just, see, this is the angiographic finding after thrombosection. And you see that stent is there. And it was predominantly, what has happened is, in the ostial, probably the stent has recoiled. The lumen area in the proximal LAD is definitely not much. And there is some amount of endothelization and a lot of thrombus there. So in this case, instead of putting one more stent, what I have done is, I have put a bigger balloon there and adequately dilated the stent, and I have just left there with good TIMI3 flow. Where if I had to put one more stent, probably it adds a lot of problem, where in the ostial LAD to left main, I have to put a stent. But imaging clearly showed a stent under expansion, which is a clear cause. And then probably after dilatation, the stent was well expanded, and we have just left it like that. And one more case of subacute stent thrombosis, you see here on this stent boost, we saw that there is some problem here in this region. Probably that is the reason why this patient had stent thrombosis. But on OCT, totally the image was totally different. See, this is the angiogram after a stent thrombosis, and then you see the OCT here. In the distal segment, the MLA is only 2 there. Probably he has significant under expansion in the distal part of the stent where the stent is not expanded, and in the proximal area it is okay. And angiographically, if I had thought, probably I would have dilated this area on stent boost and just left it. But after seeing this OCT, I have to dilate right from the distal part to achieve better MSA and then come out. And what happened is, after post-NC, again, what we could see is, we could see one more lesion in the proximal segment, which was probably in the initial setup we couldn't make out because it was done as an acute MI. See, there was a lesion in the proximal segment. So we thought, okay, in future you might require a stenting for that, but today it is, we did not do anything, only treated with only post-balloon dilatation and the areas of under expansion. And after balloon dilatation, look at this OCT, which has an excellent area at least 4.8 has come here, and good stent expansion. After this, he has never had any problem. This is almost more than 2.5 years now since we did this patient. So this is the importance of imaging when you see that. And one more thing is, as Deepak and all of us were discussing, calcium is one of the very, very important predictors of late outcomes. If you don't pre-treat calcium properly, that is, before putting a stent, you should pre-treat calcium properly, get a good lumen area, and then you take the stent. If there is inadequate preparation, you take the stent very prematurely, then definitely what happens is you will have significant problems over the course of time. See, look at this patient. He had a stent thrombosis. I have done thrombosection, and after this, what is his problem is, whatever you do, even after OCT and thrombosection, I have put a big balloon there and dilating. In spite of putting big NC balloon, it is not expanding there. The stent, you are not getting a better expansion in this spot. You see here. So the reason is there is significant calcium in that area, around that area, which is not leaving the stent to expand. The problem is it should have been prepared well before putting the stent. Then it is very, very easy. But today, this case was done almost 2.5 years back. Today, we don't have, at that time, we did not have even OPN balloon. We had to use high pressure balloon, bigger balloons at 25 to 28 atmospheres. Even that did not heal. But if it was today, I would have had an option of using OPN balloon or IVL. See, post-stenting under expansion, if the calcium is not leaving, this is also one scenario you can use IVL. Probably it will help in stent expansion. So this is one of the learning point, but this was done very probably 2-3 years back. At that time, we did not have those devices. And in spite of ballooning, that is what we see there. The OCT, the stent is not expanding, but he's still on dual antiplatelets, but he has had did not have any problem. So this patient, he had an acute MI. The previous night, my junior did an primary angioplasty in the night. And again, the next day morning during rounds, he had an re-MI in the same area. So he had an acute stent thrombosis. So what happened for this fellow at this time is, this is the angiogram you get. Again, here areas of probably under expansion or malapposition. See here, the stent was well expanded angiographically, but on OCT, you see a night, as it was a midnight primary angioplasty, OCT was not done. It was done only an angio-guided primary PDCA. And now when I did a OCT, you look at the stent, there is significant malapposition. So this malapposition is the reason for the stent thrombosis, which occurred almost 7 to 8 hours after primary angioplasty. So on angiographically, it was looking very fine. There was flow was good. We couldn't make out anything. But this malapposition was very clearly picked up on the OCT when we did for the stent thrombosis the next day morning. And again, as I told you, nothing we did. We just put a bigger adequate size balloon, dilated it, and just left it. He is doing well. And then this definitely simplifies your treatment. Otherwise, if there is no imaging, you'll have to imagine what is the reason. then take so many decisions where some people you land in putting one more stent, producing proximal dissections, all those occurs. But when you have imaging, when you know the definite reason, what is the reason for stent thrombosis, you just treat it, you come out with good results with not much of complications. And this is also one interesting case of stent thrombosis. Patient had stenting 3 years back. Now he comes back with instant restenosis, where in instant restenosis there is neoatherosclerosis with significant calcification. And beyond the stent also, you see this is beyond the stent. He has almost circumferential calcification there. And what happens is, if you're not preparing such cases properly, again, this patient lands in stent thrombosis. And here probably he required a rotablation. But anyhow, I did not use a rotablation in this case because thickness was not much. But anyhow, even without that, with high pressure balloons, I have achieved a reasonable result there. Because being an acute MI, using rota is again a problem. You should be careful. But I have used it in acute MI for nodules, calcific nodules. But in all routine cases, in high thrombus burden, rota is still controversial. This case, which we discussed in the previous presentation itself, it's a multiple cause where angiographically it looks normal. You cannot make out anything. But when you do imaging, you see this pickup dissections very clearly. You have areas of underexpansion, areas of malapposition, everything in one case. So causing stent thrombosis. So I had to stent this dissection from ear to ear and expand, put a bigger balloon and dilate in the underexpanded area, and put a bigger balloon to oppose this malapposition and create a better results. So this is the final result after this, fully expanded stent without any dissection. And we are very confident about the stent area MLA achieved. So that, and then of course, without getting complications, like if you want to achieve oversize, you land in trouble. But when you use imaging and with precise sizing and precise diagnosis of the cause of the complication, your treatment is easy and long-term results are better. And this is one more case. What has happened is, probably after stenting, this patient also had stent thrombosis. After stenting, while taking the balloon or wire, probably the guide has gone inside and then stuck there against the stent. Probably it's a case of stent malapposition, which angiographically we couldn't pick out at that time. After stent thrombosis, when we did OCT only, you could see that the stent was damaged. And you see here, this is probably a guide which has crushed the stent in the ostial LAD. And probably that is the reason, or probably rewiring, we would have put a wire there and then dilated here. We are not sure what had happened in the initial sitting. But this is definitely a stent deformation which has caused stent thrombosis. Without imaging, you cannot pick this up. Angiographically, everything looks normal. So to conclude, in stent thrombosis, especially stent failure, imaging is very, very important. If you don't have any imaging, most of the time you'll have to treat empirically. You keep all the causes of stent thrombosis in mind and then exclude, take a decision and give empirical therapy. And of course, if possible, OCT is a must in all cases of stent failure. And I think in real near future, it will become a class 1 indication for OCT in stent failure. Thank you.
Thank you. Thank you very much, Dr. Selvalmani. We have covered a lot of topics on imaging, the help, how do we use imaging in complex scenarios. I sum up by saying that I don't have, I have a couple of more questions before I do that. Can we choose the modality according to the superficial versus deep calcium among scoring, rota, or IVL? How you choose?
In a calcified lesion, that is correct. Actually, we have so many devices, starting from rota, cutting balloon, scoring balloon. We have laser, we have OPN balloons, and now we have IVL. So how you decide is a very, very important thing. See, if it is a very superficial calcium, that is, if the calcium is luminal, as Deepak was saying, we cannot take bulky devices. You cannot take OPN balloon or you cannot take IVL balloon there. In such cases, we have not much of option. We'll have to do rotablation. There are some lesions where if you can wire, then it is okay. Then you can take the rota burr over that. But there are lesions where even wiring is difficult. So if you cannot wire also in that lesion, only option is to use laser. So, but if you today, as of today, when I use rota is, if I cannot take any device, then I use rota. If I can take a OPN balloon or a IVL, probably that is sufficient. If you can take it to the spot where there is significant lesion, probably IVL and OPN will help you to get away without using rotablation. And